advocates who turn progressive ideals into action. Live Special, a project of NCJW Cleveland that supports individuals and families anytime they have a special need, temporary or permanent, has partnered with our Women's Health Series to bring you today's program. Our goal is to educate and provide a hopeful look at today's memory care landscape. Dr. Jagan Pillai is the director of Cleveland's Alzheimer's Disease Research Center and the Center for Brain Health at the Cleveland Clinic. He's a board-certified neurologist and diplomate in behavioral neurology and neuropsychiatry, and holds the Iverson Endowed Chair in Alzheimer's Disease Research at the Cleveland Clinic's Center for Brain Health. Dr. Brian Appleby is a neuropsychiatrist who treats and researches cognitive disorders. His clinical and research interests include prion diseases, frontotemporal lobar degeneration, and young onset dementia. He is a professor of neurology, psychiatry, and pathology at Case Western Reserve University and University Hospitals Cleveland Medical Center. Our speakers will be sharing a wealth of information that will inform and help you understand memory disorders, recently approved treatments, and provide a look at what's on the horizon in research and innovation. There will be time at the end of the program for a few questions, so feel free to ask them in the chat box at the bottom of the screen. Just a reminder that this is an educational program, and please do not ask for any specific medical advice or questions regarding a hospital or doctor. So let's begin. Dr. Pillai, what is normal aging versus concerning memory change, and what are some of the common causes of memory disorders?
Well, thank you, Nancy, for inviting us to this session, and thanks to the NCJW Cleveland for making this happen. It's a great time to talk about these questions because there's a lot of activity going on in Cleveland in this space, and this is a perfect opportunity for our audience to become acclimatized to that. In terms of your question, we're really talking about how do we think about memory as we get older. Memory is a core aspect of human life. It kind of defines who we are, gives us identity, helps us think about what's meaningful for the future. So when there's changes in your memory, you're also thinking about, what does it mean and how am I changing, and what does it mean for me as I plan and think about myself in the future. And for me, it helps me to think about three buckets of memory changes. One is memory, when we think about the memory from long-term past, like what school did I go to, or the day I got married, or things of that nature. They're called long-term memories. The second is what we call short-term memories. Those are memories related to what did I have for breakfast, or what was the last person I just had a conversation with. And there is also the immediate memory. That's the kind of memory that tells you about how did this session start, and how did you introduce yourself, and things of that nature. So when we think about these three buckets, most people tend to retain their long-term memories very well as they get older. But most of the challenges are coming in those two other buckets that are what are called short-term memories and immediate memories. So these kinds of memory changes in these two areas, short-term and immediate, have a lot of different causes. For example, lifestyle factors like, sleep, or your mood, or some medications you might take. Oftentimes they affect your immediate memory. So those are the reasons why you walk out of a room and you may not remember why you walked out of, or in terms of, keeping track of a conversation that's happening and getting all the details in. But conditions like Alzheimer's disease, or other kinds of changes going on in the brain that affects the memory part of the brain, often affects the ability to remember salient details like what you had for breakfast, or the last conversation that was significant to you. So different reasons you can cause different kinds of memory problems. with normal aging, it's sometimes people do have some immediate memory problems because of lifestyle changes, and then usually their short-term memory for what they did is preserved. If these are getting affected a lot more than expected, and it's starting to impact your daily life, then that means it's something that's more than normal aging that needs to be looked into.
Well, that's that's a lot of good information. I'm going to shift over to Dr. Appleby. And why does early diagnosis matter?
Thanks, Nancy, for having us. We really appreciate it. Of course, we work very long together in the Cleveland Alzheimer's Association, so thank you for all your work with that as well.
You're welcome.
I think there are a lot of different reasons for people to have an early diagnosis. One, as you heard from Dr. Pillai, there's a lot of different causes of memory loss. Some of them are more severe than others, and some are more treatable than others. So, for example, depression can cause memory loss, vitamin deficiencies, thyroid problems. All these things can be easily detectable, potentially treated. So that's probably the initial reason to get an early diagnosis or to be seen earlier. Second is, as you'll hear later when we start talking about the newer treatments, a lot of the treatments that we have specifically for Alzheimer's disease are somewhat stage specific, meaning that they're dedicated for people in the earlier stages of the disease. And they may actually be more helpful the earlier that you capture it. So earlier diagnosis is important for that.
Mhm.
Early diagnosis is also important because people need to plan for the future. If you fortunately are diagnosed with something that is a progressive brain illness, you'll want to do things differently in your life. For example, make sure that appropriate documents are made, that your care needs are known by your family members and your loved ones. So I think those are the main reasons to seek an earlier diagnosis. And of course, if there's any concern, there's a therapeutic benefit as well to being told that things are okay. And I'm fine with seeing people for that as well, because that's important.
Sure, absolutely. Dr. Pillai, can you give us an overview of the new FDA-approved therapies for Alzheimer's disease? And in simple terms for our listeners, how do these treatments work and who may be eligible for these treatments?
Yeah, absolutely. I mean, this is a very exciting time in the field of Alzheimer's disease, mostly because of the amount of work that's going on to try to come up with a solution and for a cure for that. So for many years, we are the workhorses of treatment of Alzheimer's disease was two medications. That's donepezil that was approved in 1996, and memantine that was approved in 2003. Then since then, and there has been a kind of a lull in new medications coming out of in the field, which doesn't mean that we were just sitting on our hands, but there were a lot of work going on in the background trying to understand what's causing the disease, what's driving it, and what are the key factors to target. And since 2022, there have been a slew of medications that have been approved by FDA. Right now, there are two medications available in the clinic for patients who are appropriate for this disease. That's a lecanemab that was approved in 2023, and donanemab that was approved in 2024. So what these medications that kind of have long names, but they do want something in common. They go in and connect or like fix against the amyloid protein. That's one of the primary factors in Alzheimer's disease, and remove it out of the brain by binding to it. So this goes in, sticks to the amyloid protein, removes it out of the body, and thereby, slows down the harmful effects of amyloid on the brain that is thought to be one of the reasons why people have cognitive changes and functional changes with Alzheimer's disease. So these medications are available in the clinic, but they need a lot of checks to make sure the right person gets the medication to benefit from it. They're most effective in the earliest stages of the disease, so people are still functionally independent to take care of themselves at home. So they're not available for people who need a lot of help in maintaining their daily routine, because by that time, the medication's effect is minimal. Second is you really need to make sure that there are no medical problems that makes those medications effect diluted or have more increase their side effects. Because some of the side effects of the medication include micro or tiny bleeds or some brain swelling, and that needs to be carefully evaluated. So people on blood thinners, for example, or who have had strokes, are not great candidates for this medication. There are also other risk factors like, your genetic status for side effects, being on other medications that may interact with it and all that. So your physician has to go through a lot more close monitoring to make that decision. But somebody needs to have a formal diagnosis of Alzheimer's disease using specific tests that are now available to also get access to these medications. But it's exciting. There are a lot more options on the table. People are really getting evaluated, and many of our patients, for both Dr. Appleby and mine, are on these medications.
Mhm. Okay. Thank you. Dr. Appleby, what are the benefits and limitations of these new treatments, and why is it so important to meet with a specialist?
Yeah, so the goal of these treatments is to slow the progression of cognitive decline in people that have early stage Alzheimer's disease. So it's not going to improve someone's memory, it's not going to keep it from getting worse, but will slow it down over time.
Mhm.
The limitations is, it's not a cure, but it's what we have. It actually is the first treatment that we have that affects the disease process itself. So, whereas it may sound a little bit clinically underwhelming to people, it's actually a very big breakthrough scientifically. And I think it's really the first step that we need to take to make larger strides. The
Mhm.
other limitations, as you heard from Dr. Pillai, there's a variety of other medications and other medical conditions that may actually exclude you from getting the treatment. So it's important that you have the appropriate screening for that. And that includes looking at your brain using a brain MRI, looking for blood vessel disease, looking at your genetic risk factors for some of the side effects that these medications take. So, with one exception, these are IV infusions, meaning you go to an IV infusion center, you get an IV, and that's how the medication is administered. Anytime you get a medication like that, there's always the risk of transfusion-related reactions or infusion-related reactions. We're not transfusing with any blood, I promise. But these can be mitigated pretty easily by giving you some medications beforehand. The more concerning potential side effects are brain bleeds and brain swelling. And we can mitigate that risk again by looking at your genetic potential. This is something called the ApoE gene. There are some people that may be at increased risk of these side effects and some of those that aren't. So we can tell you that. Um, and the way that these medications are given is there's a very tight schedule of how you're giving the medications in relationship to a series of brain MRIs that will be done to look for early signs of brain swelling or brain bleeding. And in the vast majority of cases, people that do have those side effects don't have any symptoms from it because they're initially caught on those brain MRIs. And that allows us to deal with that side effect in a way that hopefully doesn't affect you clinically and may actually allow you to go back on the medication at a later date. The other limitation, as we alluded to earlier, is it's stage dependent. These are for people in early stages of the illness, not in people in middle or late stages. Um, so,
So is there anything available for people who are in the later stages?
yes, the donepezil and the memantine that Dr. Pillai showed on his slide can be given throughout the course of the illness. It's still a little bit up for debate whether or not we're going to continue these new infusions over long term, but right now they're still relatively new. We don't know a whole lot about them, including the benefits at later stages of the illness.
Mhm. Okay, makes sense. Dr. Pillai, you're the director of the Cleveland Alzheimer's Disease Research Center, and I'm not sure how many of our listeners are aware of this extraordinary program here in Cleveland. Can you please tell us about the CADRC?
Absolutely. Alzheimer's disease burst into national consciousness in the late 70s, early 80s, when it was seen as a real challenge for society, because we saw that this is going to hit large numbers of seniors and we needed a cure that affects and that's meaningful for all sections of society. in a way that's scalable and making a lot of impact. So the NIH and the federal government invested in these Alzheimer's disease research centers starting in early 80s. They picked key academic institutions and they made sure that there are resources to develop new understanding of the disease. They do this by two different ways. One is by evaluating a cohort of people over a long period of time so people can enter this study and be followed over a long period of time to understand what's going on. So insights from those studies, along with research that is generated through investigators using, specimens that are collected like blood or brain scans or spinal fluid evaluations or PET scans, all these things, went on to supercharge our efforts in finding new therapies and understanding what the disease is. So this has been a multi-decade effort that has been going on. And Cleveland has been part of this journey for many years. So we had an Alzheimer's disease research center in Cleveland, about a decade ago, for many years out of case. And now it has come back to Cleveland. About 6 years ago, we are one of 35 centers across the nation. And this ADRC, the Alzheimer's Disease Research Center, is unique in that it's a citywide effort. So all the major institutions in the city, the VA, Case Western University, University Hospitals, Metro Health, and Cleveland Clinic have come together to pool their resources to generate a groundswell of support of Alzheimer's disease research. So these resources are available to all of Northeast Ohio and beyond. So we're very, very excited about it, and we just applied for a renewal funding from NIH, and we are eagerly awaiting results from that soon.
No, well, that's great. I have found this to be so exciting to hear that the big players in town are all working together for the same end. I think that's amazing. So I'm going to ask both of you, what are the important questions that researchers in Alzheimer's disease are asking these days, and what role can our audience play in it?
Yeah, I can start out and have Dr. Appleby add to it. I think the main thing is that the initial phases of research has allowed us to think about Alzheimer's disease as core features of these two pathologies, amyloid plaques and tau tangles, that go on to affect brain changes and later on cognitive issues. So over a period of time, we also recognize there are other players in the game, like for example, whether you have vascular or blood vessel related changes going on in the brain or the nature of the inflammation happening. But the key thing that we are recognizing right now is that how Alzheimer's disease affects each person is different, because each of us has a different mixture to us. I mean, maybe we have a different experiences in our life, environmental exposures, genetic differences. All of these things go on to modify how Alzheimer's disease actually expresses itself. So some people can have very slow change or a lot of, despite having changes from Alzheimer's disease going on in the brain, they're still asymptomatic for a long period or have a very slow disease progression, whereas others have a much faster rate of disease progression. So why is it happening? Why is the story different for each person facing the disease? I mean, that's one of the conundrums that we are facing now, and researchers are honing, including in the ADRC, trying to answer this question so that we can help each person where they are to find out solutions for Alzheimer's disease as it affects them. I would say that was one of the key questions researchers find fascinating and are think that are important to answer the next stage.
Brian, do you have anything to add to that?
Yeah, I think research is fundamental to understanding the illness. And Alzheimer's disease is an extremely complex disease, and we don't really understand what causes it. We know the two pathologic proteins that are associated with it, but what starts that process, right? We know a variety of risk factors, but none of them by themselves are, complete to cause the disease. So understanding the disease allows us to know how to better diagnose it, but also how better to treat it. And this can be done in a variety of research centers. So you can do this through, The ADRC, which is a natural history study, it helps with examining what people look like, as Dr. Pillai said, rates of progression, symptoms, and how that's individualistic, but also what do their biomarkers look like over time? Things like measures of inflammation, measures of amyloid, of tau, things like that. And then ultimately, looking at people's brains that have went through this, helping to understand what actually happened. Because we do have some tools that can help us understand while the person is living, but we have many other tools that don't allow us to do that. So we've primarily talked about Alzheimer's disease, but by far the most common cause of cognitive impairment in people is multiple causes. When you look at people's brains after they pass, most people have two or more pathologies. And some of these we don't have any diagnostic marker during life. So these studies allow us to possibly detect these other illnesses that come with Alzheimer's disease and allows us to make a diagnostic test. That diagnostic test then allows us to be able to intervene with a potential treatment earlier. I mean, that's what happened with Alzheimer's disease. We have much better biomarkers that we can use clinically now, and that coincides with these new treatments. So we need to do that for all the other pathologies as well. And then it's very important that we remember it's not just the patient themselves that are part of this journey, but it's the family as well. And it's extremely stressful for families, and they deserve to be studied in a way that enables us to help them the best that we can as well.
Wow. So I know one of the questions that will be coming up, so I'm going to ask it now, is how can someone participate in a research study?
Yeah, absolutely. I mean, Cleveland has a rich set of resources for anybody interested in research. I mean, there are different avenues that you can take part in. Broadly, there are two kinds of research. One is what is called an observational study, and these are studies that are evaluating people over a long period of time to see how things change. I mean, these studies could be eligible for people, for example, with a strong family history of Alzheimer's disease, or somebody with changes or cognitive changes from Alzheimer's disease itself. The second kind of studies are called clinical trials for therapeutic medications that they're trying to see if they're helpful. So they usually involve people who involve people who have known disease, and they're trying in novel therapies that could, slow down or stop the disease progression. So both of those, research studies are going on in Cleveland area institutions. The Cleveland Alzheimer's Disease Research Center is an example of an observational longitudinal study. So when you enroll in the study, you have a yearly evaluation using cognitive tests and blood tests and brain scans to better understand how and why things are changing over a period of time to help to understand the signs of the disease and find fundamental answers as to how to cure this disease going forward. And that, ADRC, you can just sign up for that and using from our web page. There'll be a contact information. You send an email, then someone is going to be in touch with you to see if you're eligible for being in the studies or not. The clinical trials are usually happening in the setting of clinics, whether it's UH or CCF, and they have options for different therapeutic trials that they would have to evaluate whether a person is candidate for. Anything else, Brian?
Yeah, no, I think just contacting one of the main centers in Cleveland, I think an excellent entry point to research are these observational studies like the ADRC. In many ways, they become a platform that we use to recruit for other studies as well. So it allows us to very easily reach out to you for any new studies that may happen that you may be eligible for. So I think it's just a really easy first step is something like the ADRC.
Okay. Dr. Appleby, you mentioned to me about basic science studies. Can you explain that? And if you've
Sure.
talked
So
about that, I wasn't sure that which were basic science and then which were the clinical ones. So maybe you could clarify that for me and everybody else.
Sure. Well, they all kind of blend together, but usually when we refer to basic science, it means that it's not patient facing. So it's usually looking at specimens that are taken from patients, or even animal models or molecule studies of the disease that we're looking at. So it's not facing the patient, but many of the specimens that are obtained through clinical studies, like natural history studies or observational studies, are used in basic science. That's where everything starts. And that's how you know whether or not you have a compound or a drug that may have an effect on the disease. Then you move that into an animal study like a mouse model. And then after you prove that maybe it might work and that it's safe in a human, you can go on to human trials. There's kind of two broad categories of basic science, something that we call wet lab and dry lab. So wet lab, think of it as kind of your high school biology class where you're doing things with specimens and with chemicals. And that's extremely important. But equally important is what we call dry lab research. This is number crunching. This is looking at large population data sets, doing things like epidemiology to find associations between things that may actually affect someone's risk or affect someone's course over time. So I think those are kind of the large groups of studies that people should know about and maybe even consider participating in.
Thanks. That's very interesting. Switching gears a little bit, the U.S. pointer study is one that there's been a lot of interest and excitement about, and it has to do with lifestyle changes. Can both of you or one of you talk about the U.S. pointer study and what the results mean for all of us?
Yeah, I like to refer to the study. I think they should have used the acronym MOM because it's everything that mom told you to do is actually correct, right? So the Pointer study looks at healthcare interventions, and we know that lifestyle factors play a huge role not only in someone's risk, but even in their progression when someone is actually affected by the disease. So things like exercise, diet, addressing hearing loss, socialization, cognitive activity. These are all things that have a profound effect on not just your risk, but how you progress if you have the illness. And a lot of this has been known for a while, but with the Pointer study and the Finger study, which is the international equivalent, we're now doing proper research and quantifying this to know how much it actually helps and the fine details of these interventions that may help all of us. Delay or prevent the illness from happening in the first place.
You
Dr.
know,
Pillai, did you have anything to add to that?
one of the things I found interesting in the Pointer study is that we all have good intentions, but oftentimes we don't follow through on that. And what the Pointer study showed is that if you have a structured regimen to make sure you're following through on these instructions that mom gave you, you're more likely to benefit rather than having just good intentions. So basically, they've been when they ask people to actually rigorously follow the instructions, more people benefited rather than just having a good intentions to practice. So it brought home to us that yeah, we really need to make sure we are actually implementing what we want to do in our lives.
So is it ever too late to benefit from lifestyle changes?
No, I mean, lifestyle, I think the key word is life, right?
Mhm.
It's across the lifespan.
I hope we're all listening to that because I'm going to keep thinking of it as the mom study. I think that's perfect. The Cleveland Clinic is home to the women's Alzheimer's movement. Dr. Pillai, can you talk about that a little bit?
Yeah, absolutely. Sorry, it's my clinical page around. Uh, the one of the risk factors for Alzheimer's disease is genetics. One of the genetic risk factors is ApoE4. Another risk factor that affects what age you get Alzheimer's disease and your risk for that is actually being a woman. Women have been seen to have a slightly higher risk for Alzheimer's disease as they get older. And the question is why? It is true that women tend to live longer than men, and so the chance of having age-related changes come up is higher. But recent research suggests that maybe that's not all there is to it. Maybe other factors, maybe hormonal changes, maybe something in the genetics or exposure could play a role as well in increasing risk, including differences in immune response in men and women. So those are being evaluated as part of the Women's Alzheimer's Study movement, and where they're encouraging research studies and providing funding to help understand this conundrum. And we hope to hear more from them soon.
Okay, well, this has been great. You've provided so much information, and it's interesting, it's informative, and it's helpful. And we're going to switch over to some of the questions now because we've got a lot of them coming in. And I am going to start with one, which is, what's one thing about memory care that has changed the most in the past few years?
I think diagnosis. Um, Before it was mainly a clinical diagnosis, meaning diagnosis of exclusion and things that may be suggestive, looking at the collection of clinical symptoms and matching that with an illness. But now in most of these illnesses, we actually have a biomarker that is indicative of the illness. And that's a game changer. It's like trying to diagnose a heart attack without an EKG. And now we have the EKG.
Okay. What are the different kinds of cognitive disease and how do they differ from Alzheimer's? I think that one was for you, probably, Brian.
Yeah, so if we're just talking about progressive brain illnesses, which means that this is something that starts in the brain and affects the brain. It's interesting. They all have one thing in common, and that's due to the misfolding of a normal protein that we all make. Um, the difference is the protein affected in each of those illnesses. So for Alzheimer's disease, it's A beta and tau, and Parkinson's disease and dementia with Lewy bodies, it's alpha-synuclein. And those misfolded proteins tend to occur in different areas of the brain. And different areas of the brain dictate what symptoms people have. So, probably the three or four major progressive brain illnesses that we think about are Alzheimer's, dementia with Lewy bodies, and frontal temporal lobar degeneration. Um, and they're all going to look different clinically. They're all going to have different diagnostic tests. They all have different treatments. And of course, they all have different things that we would educate patients and families about to look forward to in terms of what they need to be paying attention to. It's important that we look at all of these because, again, when we look at brains of people affected by these illnesses, it's not uncommon to see evidence of all three of them. We like to categorize people and put them in nice boxes, but that's often impossible to do if we're going to be truthful about it.
So do these other cognitive diseases fall under that umbrella of dementia?
Yeah, dementia is a symptom. It's equivalent to having chest pain, right? So you have a lot of different causes of chest pain. And those illnesses that I mentioned, Alzheimer's disease, dementia with Lewy bodies, those are all causes of dementia, much like a heart attack or a pulled muscle or pneumonia could be a cause of chest pain.
Okay. So for prevention, we are told to get 7 to 9 hours of sleep. Why is more sleep at night not recommended? Why is more sleep at night? I'm not sure I understand that question. Do you? All right, I'm going to skip over and maybe Rita Rome can rewrite that
I think they might have
question.
been asking, why isn't more better?
Why is more better?
Oh, okay. I'll take that one. Can you respond to that then?
Do you want to take that one, Jagan?
Okay. Let me rephrase the question as we have 6 to 7 hours of sleep. How come more sleep is not better for your brain health? And I think, I would like to think about it that like everything in life, there's a balance. and more of it is not necessarily great. Actually, one of the signs of cognitive impairment is that the duration of your sleep tends to increase. So people with some kinds of cognitive impairment actually tend to take a lot more naps during the day that is unusual for them, or tend to spend more time in bed than needed. So that is usually a sign of the brain not able to reset itself and do what it's supposed to do, which is basically be engaged in their daily life. So that is something that would trigger an evaluation, see what is going on.
Okay. What kind of diet do you suggest is best for prevention of memory loss? I know what I think it is. I'm hoping you'll say the same thing.
I mean,
I'll let either of you go to that one.
it's yours, Brian.
Yeah, I'm an extremely simplistic person, so you can get into like the details of how many blueberries and all that stuff. But most people would recommend the Mediterranean or Mayan diet, and I think that can be easily simplified by saying lots of fruits and vegetables, low fat, low cholesterol, and minimize red meat intake, and prioritize either no meat or fish and chicken. That's how I would simplify that.
I'm very glad to hear that answer because I've been trying to do more with the Mediterranean diet. So I was glad to hear that one. This is a question that I know gets asked so often, which is what is the difference between Alzheimer's and dementia?
I think, Dr. Appleby just mentioned that as part of his response. The key thing is dementia is we use the word dementia if a person is having changes going on in the brain because of which they cannot handle their daily routine and their daily life independently. So it's basically a sign that this person cannot live on their own and they need help to manage it because without that additional help, they tend to have problems that leads to hospitalizations and other complications. So dementia is really a way to signal that this person needs help beyond what they can do to take care of themselves because changes going on in the brain. The dementia can be from a lot of different reasons. It can be if a person is having a lot of strokes, it's called vascular dementia. If a person is having Parkinson's disease, for example, for many years, you tend to have Parkinson's disease dementia. So Alzheimer's disease is another cause, but it is thought to be the most common cause of dementia. The second most common reason, or as common as Alzheimer's disease, is having more than one reason. That's what Dr. Appleby was also talking about. It's called mixed dementia, when people have more than one reason that causes dementia.
Are there any supplements that can help? We see a lot of them now on television and in magazines. Are there any supplements that you actually think might help someone's memory?
I can share, what I say in my clinic. There are some key, vitamins that are important for brain health, like vitamin B12 or vitamin B1 or thiamine. And usually we get them from a well-balanced diet. If you're eating Mediterranean diet, for example, and you don't have any specific, dietary restrictions, you tend to get the amount of vitamins you need. But sometimes your body does not absorb them because there may be some changes in your medical problems because of which you're not able to absorb these vitamins. Then in which case you need supplements to make sure that your body is able to take in those important vitamins and minerals that are important for your brain health. Outside of a regular diet, no specific supplement is recommended by the National Institute of Health. But if you are taking a daily vitamin, that's supposed to be, good, helping, ensuring that you're getting all the important vitamins in. We don't specifically recommend a supplement regimen. However, hope springs eternal. You want to be always at a younger age than we actually are. And people do use a lot of supplements that they find from their primary doctor or from functional medicine. We tend to review them as long as they're not having any strong interactions with some of the medications they might be taking, because some of the supplements, for example, don't go along with a blood thinner. So you really need to make sure that these things are getting adjusted and they're not counteracting each other. with your doctor. Outside of that, I think it's good.
Okay. One of the questions is, what is the most critical risk factor?
You're not going to like it, but age.
Oh,
Yeah, that's by far
that
the
O
number.
is for a lot of us in the audience here.
Yeah.
Yeah,
So what do we
unfortunately.
do about that as we're aging?
Age gracefully, lifestyle interventions, right? But yeah, that is the commonality between all of them is age. And there's a lot of different reasons for that. Probably, a lot of this is random processes, right? Like being able to detect abnormally folded proteins. That goes down as you get older. You're more likely to make them as you get older because you've been alive longer. So age is number one, unfortunately.
Well,
One of the things
it
that
does seem like it goes back though to the lifestyle.
I was going to say that uh, one of the things that we do know is that depending on age, your critical risk factor changes. Like, for example, not only can we prevent dementia or cognitive impairment for ourselves, but we can actually think about our next generation. And so at each age range, the risk factor slightly is different. For example, at the youngest age, it's actually education. It's very well known that the higher your education or the complexity of your job, the risk of having cognitive impairment later in life is lower. At a younger age, the most we can invest in is the education part. And middle age, things like traumatic brain injury or during youth, like for example, getting into sports that have a lot of traumatic brain injury or controlling your blood pressure, your body weight, all those things also tend to impact your risk of cognitive impairment later in life. But as you're getting older, as Dr. Appleby mentioned, age is a huge factor. But on top of that, like for example, if you're smoking, or if you're so socially isolated, or you're physically inactive, I mean that tends to build up as you're getting older, and that tends to compound things. So at each age, there is a different set of risk factors that kind of comes into prominence. I would say things like keeping an eye on mood, like depression, diabetes, blood pressure, physical activity, hearing. Those are the key factors, in addition to age, that plays a huge role in their years.
Can having multiple concussions during playing football cause Alzheimer's?
I, I think that it is a risk factor. I think current science says that people having multiple brain injuries, concussions, it's not shown that you will definitely get the cognitive impairment. It can be from Alzheimer's disease or other degenerative diseases, but it is a risk factor. Like everybody who is smoking will not get lung cancer, but it is a risk factor for getting lung cancer. I mean, your chance of having this is much higher. So the same thing applies for traumatic brain injuries too.
Okay. So for both of you, when should someone seek evaluation?
So I would argue there's a role for evaluation if you or someone close to you has noticed a change in your thinking. Again, I don't mind seeing people. I'd rather see people that are the worried well than not have people come to see us with a concern. So I think if there's any concern, please be evaluated.
Okay. Well, are there any other questions that someone wants to put into the chat box? We're looking. No, we don't have any new ones. So, Dr. Jagan Pillai, Dr. Brian Appleby, on behalf of the National Council of Jewish Women Cleveland and all of our listeners today, Thank you so much for educating us about the many new and promising treatments for memory disorders. What an important topic for everyone to learn about. To our audience, if you joined the program today but are not a member of NCJW Cleveland, we would love to have you join us. There is no better time for NCJW Cleveland to be working to help women, children, and families in our community than now. Your membership matters more than ever to continue our essential work in advocacy, community engagement, and timely programs such as today's. We'll be sending out a follow-up email with a link for joining and several links with more information about resources from today's program, or you can visit ncjwcleveland.org today. Thank you for joining us and have a great rest of your day.
Thank you.